opportunity to talk about anaphylaxis. So, again, the same exercise. Please take or you can also do that. So this is a website which I was creating on my own. I was just sitting on it and I was doing it. And then I get a call from these people asking me to give a talk on this. So if you can just scroll it down, so we can also check it. So this is a website which is created exclusively to report a case of anaphylaxis. I'll tell you why it is important and why what other countries have done which we are not doing. So this is a small attempt by me and my dear friend Dr. Modi. We have conceptualized this to make this website happen. I would definitely require a feedback from you people so that we can work on it. So we'll come back to the main topic, that is anaphylaxis, recognition and response. So we go from preparedness to precision. So let me start off with a simple story. So which all of us would have gone through in our lifetime. You ask your staff nurse to start some medication. And just few minutes later, she comes back and tells, Doctor, this child has gone for a shock. What do I do? So that's not unusual, isn't it? How many of you have had such experience? Please raise your hand. So this is the hospital setting. Let's give another example. Our beloved Dr. Parmesh. Once he had gone to Nilgiris, Ooty, where he was having his favorite meal. He knew he had an episode of anaphylaxis in the past, and he had specifically asked the chef not to prepare anything out of fish, which he duly did. He served, and then he ended up having one more episode of anaphylaxis. The food was not fish. The only mistake what he had done is he had used the same ladle which he had prepared. So I'm giving you two scenarios. One is a hospital scenario, one is a home scenario. So let's see how we go further from these stories. So in this talk we will discuss about the definition, recognition, causes, management and preparedness. So these are the few topics which we will be discussing today. Charles Richet and Paul Potier in 1902 coined the term anaphylaxis, which simply means against the protection, anaphylaxis. And if you have seen, a lot of deaths have been reported all across the country, and this one probably was from, these two are from the Kerala. Our primary agenda here is, at all costs, prevent deaths from anaphylaxis. That's our primary agenda. That's a vow which we need to take. So next question what I'm asking is, what is the commonest cause of fatal anaphylaxis? Is it the drugs, is it the food, or the insect sting? Please answer. What is the most common cause of anaphylaxis? What is the most common cause of fatal anaphylaxis? Okay, we'll go into that a bit later. We'll answer those ones. So, which is the first line of treatment here? Is it the hydrocortisone or chlorpheniramine maleate, or subcutaneous adrenaline, or none of the above, or all of the above? Thank you. Okay, so this is all a base all this wastage of time was, or are the base for these subsequent slides. So let's see how common is our anaphylaxis. That is reported almost about 46 cases per lakh population per year. And reported incidence is anywhere between 1 to 761 per 1000 per years in children. That was the total number of cases, and this is in the children. And let's look at the prevalence. The children with a history of anaphylaxis at a given time is total anaphylaxis is anywhere between 0.04 to 1.8%. And for the food-induced anaphylaxis, prevalence is reported between 0.3 to 1.2%. Okay. So this is issue from the Korea. No, it was published in Allergy 2023. And these are some of the publications from the Spain. There also they admit that there is incidence of anaphylaxis has gone from 1998 to 2011, and UK has a similar study where if you look at this, have increased from 1998 to 2018. This is a publication from 2018, but what they say is the cow milk case fatality has fallen down. So as you can see, there is a steady increase in the number of the cases, the milk, unknown cases, peanuts, tree nuts, and unidentified causes. And if you can see the number of deaths, there has been a steady decline in the cases of anaphylaxis. All that has happened only because they were ready, they were prepared to handle a case of anaphylaxis, which we should be. And this is where this class becomes very important, this session becomes important, because preparing for anaphylaxis is just not limited to the hospital environment. It can happen at homes, it can happen at schools, it can happen at any hotels, it can happen anywhere. So being ready is the only way to prevent the deaths from happening. So as per the definition, Dr. Neeraj also mentioned about the diagnosis part of it. Anaphylaxis, because we had two system involvement in the case which you mentioned about. Anaphylaxis is a severe, life-threatening, systemic onset of potentially life-threatening airway, breathing, or circulatory problems, and is usually, although not always, associated with the skin and the mucosal changes. This is a statement as per the WHO, World Allergy Organization, and YACI. So the point here, what we need to note is, we need not have all the classical features to make a diagnosis of anaphylaxis. So let's look at the criteria, how we make a diagnosis of anaphylaxis. Anaphylaxis is highly likely when one of the two criteria are fulfilled. One is acute onset of illness, that is within minutes to hours with simultaneous involvement of skin, mucosal involvement, or both. Okay. So, and when there is already and at least one of the following, that is respiratory compromise, decreased BP, or severe gastrointestinal symptom, when a person is already known to have a food allergy. Okay. So acute onset of hypotension and bronchospasm or laryngeal involvement after exposure of a known or a highly probable allergen. So that means here we have two criteria: when you already know what you are allergic to, when you don't know what you are allergic to. So these are the two things what we need to know. So the point here what we need to know very clearly is, absence of skin symptoms does not rule out the diagnosis. So being very vigilant is the most important part here. So we'll start off with another case. Here we have a 2-year-old child suddenly comes with a history of difficulty in breathing and collapses following a vaccine. Could it be asthma, sudden attack, Could it be anaphylaxis? No, 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 it's just a foreign body aspiration. What could it be? You probably are mostly dealing with anaphylaxis. So here comes the important point, and that is symptoms appear as per the age of the child. Skin symptoms are very common in a younger child. Respiratory symptoms like cyanosis to stridor in younger children, to wheezing and dyspnea as they grow older. So they can present with a sudden episode of cyanosis and a stridor at a younger age, but as they grow older, they can present with other symptoms like wheezing and dyspnea. Gastrointestinal symptoms are more commonly present, that's nearly up to 50% of the cases, and this is more common in children less than 3 years of age. Dizziness, hypotension, loss of consciousness is observed in older children, adults and adolescents. So please remember, not all the symptoms appear at every time. It is the age what decides how we present at a particular point. So this is from the European reporting anaphylaxis registry. So if you look at the gastrointestinal symptoms, at birth the vomiting is more predominant, and the cough is also pretty high, and the symptoms of neurological presentation is very less. But as you grow older in the age, your symptoms change drastically. You can have vomit. As you grow older, you can have cough, and as you grow older, you can have dizziness and hypotension as your presenting symptom. Okay, so this is as per the European registry. We are talking about registry all the time. This is what we are trying to make out of that website. So it is available freely for everybody to fill it up. If you have any such case, please fill it up. It is only going to do good for the society for the future. So the answer to that question is children may present as an acute severe exacerbation of asthma, that is predominant respiratory system symptoms as a part of systemic allergy symptoms. So along with recognizing urticaria, angioedema, laryngeal edema, pharyngeal edema, abdominal cramps, difficulty in breathing, what patients come, at least an older patient is feeling of that impending doom, that something is going to happen to me, I'm going to die right now. So this is one such feeling every anaphylactic patient is going to explain if they can vocalize. So this is something which you really need to keep in mind. So of course you listen to them, but this is one thing which you need to ask. You will know that you are handling a case of anaphylaxis. If a patient comes to you and says, look, something is going to happen to me, don't neglect it. So what are the triggers or elicitors? Food. As per the Korean registry, this is as per the Korean registry, of the 991 cases, 740, that is nearly 75% of the cases were food allergies. Drug and the radio contrast media constituted about 10%, idiopathic was about 9%, exercise and insect stings were less. But you must remember that drugs and the radio contrast media, they constitute the most number of fatal anaphylactic events. And this is as per the European registry, where the cow's milk, egg, cashew, hazelnut, peanut, Dr. Krishna was mentioning about all of that. As you grow older, their children do outgrow the cow and the hen's egg, whereas other things will still remain the same. So we come back to the same point again. Younger the child, higher proportion of food triggers. This is as per the age. If you can see, 0 to 2 years, they constitute nearly 36% of all the cases. 3 to 6, another 27%. 7 to 12 is 19%. So, pediatric age group is the age group who have the maximum number of anaphylactic cases. And this is where our job as pediatrician becomes very important, just not to handle the cases in emergencies, but also give them the idea of what anaphylaxis is and be prepared for it. So, many of them also have a past history of allergic diseases. And if you look at the commonest cause of triggers, which I have already mentioned: food, milk, egg white, peanut, soy, tree nuts, wheat, buckwheat, crustaceans, and fish. So these are the commonest causes, whereas the milk still constitutes about 28%, and egg white is about 13%, peanut is about 6%. Okay. So this is a Korean data. UK data is not very different from that. It is very similar to that. And we all love to rank. So this is one such ranking system. One in South Korea, one in Asia, Europe, and USA. So the predominant cause in South Korea is cow's milk, whereas in Asia it is shellfish, Europe it is peanut, and the same is with USA. The number 2 cause is, of course, the eggs and cow's milk. There are some factors and cofactors which you need to keep in mind. So, infants who cannot describe the symptoms are at a very high risk. And adolescents and young adults, as you all know, they are at a very risky behavior nature. So they are likely to end up in severe forms. And labor and delivery, risk of medications, antibiotic to prevent from infections. You also see a lot of cases in the labor and delivery cases. And elderly people, because the risk of fatality because of the medications and the venom triggered anaphylaxis. This is an image which is directly taken from the World Allergy Organization. And the cofactors that amplify the anaphylaxis is the exercise, acute infections, emotional stress, disruption of routine, and premenstrual stress. So let's come back to that, each one of the stories. Can anybody tell their own experience regarding each one of that? I'm pretty sure all of you would have had some or the other experience. Sir? Joseph? Exercise induced. Most common. And acute infections. They also trigger an event of anaphylaxis. Emotional stress. If you are emotionally stressed, you are likely to end up in anaphylaxis. And disruption of the routine. You know, if somebody is used to sleeping and waking up at a particular point, their hormones are not changed, their routine is not changed, nothing happens. The moment they go to a different environment, their sleep patterns are changed, they're stressed out, they also end up having a anaphylactic event. And premenstrual period is one such period which is very vulnerable for the event of anaphylaxis. So let's come to the most important part, location of anaphylaxis. Home is where most of the anaphylactic events, this is as per the European history, where it is 48% of the cases happen at home. Schools, hospitals, restaurants are the other places where you can have anaphylactic events. The rest all constitute nearly 50%, whereas home alone constitutes to 50% of all the cases of anaphylaxis. Be prepared. So is anaphylaxis underdiagnosed and poorly treated? Of course, it is very poorly detected and treated. So before we go for the management, after we have recognized, we need to grade the anaphylaxis. This is the grading system what WAO gives us. So I have tried to simplify it by giving these simple lines. Anaphylaxis with systemic generalized skin manifestations and subjective symptoms, that is grade 1. Anaphylaxis with predominant gastrointestinal involvement, grade 2. With predominant obstructive airways, lower airways, that is grade 2 and 3. With predominant obstruction of the upper airways, that is 2 and 3. Cardiac and circulatory system involvement, 2 and 3. With cardiac and circulatory arrest, it is grade 4. I think I've tried to simplify it by giving simple line answers, single line answers. So if anybody comes with a history of hypotension, low heart rate, you probably are staring at stage grade 2 or 3. And if somebody has collapsed, it's definitely grade 4. Okay? So most of the cases with food are probably at 1 and 2. If in the hospital, since you are injecting it, the load is high, they may end up having a severe anaphylaxis. And let's come to the adrenaline dosages. 0.01 mg per kg body weight to max of 0.5 mg. This is equivalent to 0.5 ml of 1 in 1000 adrenaline. So what we get adrenaline is 1 in 1000 ampules. For children up to 10 kilos, that is 0.1 ml per kg. If a child is about say 7 kilos, you can go up to 0.1 ml per kg, that is 0.7 ml. And between 1 to 5 years, that is 0.15 ml of 1 mg of 1 in 1000 adrenaline. Between 6 to 12 years, it is 1 mg, and then for teenagers, it is say 0.5 to 1. So as you grow older, the dosages also need to be increased. So instead of asthma action plan, I call this as anaphylaxis action plan, where we have a written management plan for anaphylaxis. Remove the triggers. The first case which I mentioned was about a drug which was being infused. The first and the foremost thing what you should address to that staff nurse is stop the medication. Remove that IV line, not the cannula, just the drip. And then assess the ABC, mental status and the PMI, and most importantly, call for help. Don't try to deal all alone. Call for help. Inject adrenaline and record the time of administration, because you can go up to 3 to 4 times of adrenaline at a given time. If a child is not responding, give another dose of adrenaline. And place the patient on the back, position to comfort. Do not allow patients to sit or stand suddenly, because orthostatic hypotension can happen. So make sure that they are on a lying down position. Give supplemental oxygen if needed. Establish an IV line with a winding bore cannula, and if needed, we can also consider doing a CPR. Monitor vitals at regular intervals. But at all costs, your common sense must prevail. Don't let that go away from you. Okay? Having all that, be prepared and have some common sense. So we also should keep the anaphylaxis kit ready, which should have at least 3 vials of adrenaline, 3 1 ml syringes, swabs, notebooks and pen, and laminated guidelines in the emergency room. And in case of bronchoconstriction, give short-acting beta agonist, that is adrenaline nebulizations can be given. And further, first-generation antihistaminics have very limited role, and they instead can cause hypotension. Okay, so this is one thing which most of the staff nurses and the hospitals tend to give. They tend to give antihistaminics, which are only going to compound the situation. Please tune their mind to change from CPM to adrenaline. And first generation of antihistamines have limited role, and rapid administration can only cause hypotension. Glucocorticoids can be used to prevent that biphasic reaction to prevent the bronchoconstriction. That is the second wave of anaphylactants which are released, that can be managed. And parenteral glucagon in patient with beta blockers if there is no response to adrenaline, because if they are already on a beta blockers, their adrenaline may not be much effective. At that time, glucagon can be considered to give. And fluid management is also very important. And at the same time, we also should do the serum tryptase levels and repeat after 24 hours to check if it is a proper anaphylactic event or not. And we need to have a written advice at discharge is mandatory. So we also should have the trigger avoidance measures, and management in the ER, what has been done should be written, and a follow-up plan should be given by the and referred to the allergist as well. And for the long-term management, it is a tailored individual plan. One size doesn't fit all. Okay. So the discharge, post-discharge is the place where it is most severely compromised in India. Lack of awareness, non-availability of adrenaline auto-injectors. Most people call it as EpiPens. EpiPen is just a brand, whereas it is adrenaline auto-injectors. Many companies have tried to bring it to India. Most of them are priced anywhere between 5 to 7,000, 5 to 7, sometimes up to 15,000 in India. They are not easily available, but they are available at some cost. And the most important aspect in India is lack of allergologists who can guide them what to do when it happens. And Dr. Krishna Mohan was also speaking about the identification of the trigger. So this is where your detailed history taking comes to the picture. And we can also do in vivo and in vitro tests, which Dr. Neeraj Gupta spoke in detail. And we also need to give this AAP, that is Anaphylaxis Action Plan. So in case of non-availability of auto-injectors, what am I supposed to do? In rural area, I cannot expect it to be carried into a person. So at that time, we can ask them to carry a adrenaline which is preloaded. Instead of it auto-injecting, they may have to do it on their own. For that, since it is a light sensitive medicine, it needs to be covered probably in a spectacle box or somewhere where you can keep it and preserve the medicine, use it till the expiry date. The next question is, if the medicine is expired, what do you do? Please inject and get the fresh vial later. To prevent the recurrence from happening is we need to have the allergen avoidance and the desensitization which Dr. Krishna was speaking about. Medical identification alert like a bracelet or a card which can be given if they go to a hospital. They need to know, okay, this person is allergic to this, so they need to know. And record of the suspected trigger is very important. Anaphylaxis education and training is very important, and public health measures and food labeling is something which we are lacking at this point. There is a lot of leap change which has happened in last couple of years, but it is still far from satisfactory because there are a lot of fake products available in the country. The food labeling is severely curtailed in India. So with this, I come back to my original slide, that is the, please take a photograph of this. I'll widely circulate in all the groups as well. So we are trying to build a registry so that everybody in our country gets benefited with that. This is my own website registered under me. Okay. So the final message is, it is more common than thought. Incidence and prevalence is rising. Act fast because early detection is the key. Infants, elderly are at particularly susceptible levels because they have the subtle and the atypical presentations. Infants have very non-specific presentations, so they can come with constitutional, skin and GI symptoms. And we need to keep the adults and elderly because they have the IHDs and other symptoms, additional comorbids. Thank you for having patience. I know that I have overshot the time. Sorry for that.
Thank you, sir, for the excellent session. We have one more session pre-lunch. Chair, I request the